This will mainly lead to fetal hemorrhage, right? So I'm going to remember only the most important point. This is mainly associated with fetal hemorrhage. And yes, this can also lead to vasa previa. This can also lead to vasa previa. Now, this is what is vasa previa. So what is vasa previa? Only the fetal vessels with membranes will overlie the cervix. Only the fetal vessels with membranes will overlie the cervix, right? So if placenta overlies the cervix, you call it as placenta previa. If fetal vessels overlie the cervix, you will call it as vasa previa. If cord overlies the cervix, what will you call that as? If cord overlies the cervix, what will you call that as? So that will be called as cord presentation. There is no chorda previa. That will be cord presentation. Okay. So vasa previa is fetal vessels overlying the cervix. Now this can be due to velamentous like in this picture, or it can be due to bilobeta, or it can be due to subcentrate lobe. Right. So this also can present you with painless vaginal bleeding. But whose blood is going? Whose blood will come out? How will you differentiate this from placenta previa? So after the bleed starts, immediately fetal heart rate will drop, and within 10 to 15 minutes, baby can die in vasa previa. So if they give that there is an episode of bleeding which has dropped the fetal heart rate, then think in terms of vasa previa. Because whose blood is coming out through vasa previa? It is the fetal blood which is coming out. How will you diagnose this? How will you diagnose this? No, diagnosis is not, diagnosis is by transvaginal sonography with Doppler. But you should not do PV or perspectrum. But you can take a transvaginal sonography with Doppler to see for these vessels. Right? Excellent, guys. So how will you do this? How will you do? What is the management here? Elective lower segment cesarean section. You want to put incision here itself. You're not going to go for classical. You're going to go for lower segment cesarean section. Now I see many of you have written app test. Yes. Earlier days when this was Doppler was not there, we had qualitative test to differentiate feto-maternal hemorrhage. And that qualitative test to differentiate feto-maternal hemorrhage is APT test, which is also called as Singer's alkaline denaturation test. Singer's alkaline denaturation test. Okay. Next. What is the quantitative test? What is a quantitative test to differentiate feto-maternal hemorrhage? What is a quantitative test to differentiate the feto-maternal hemorrhage? Qualitative is APT test or Singer's alkaline denaturation test. What is a quantitative test? It is the Kleer-Betke test. It is a Kleer-Betke test. Or it's also called as acid elution test. Acid elution test. The next important point with respect to the Kleer-Betke test or with RH isogonization. So the simplest question which I've seen maximum times from RH isogonization is how much anti-D you should give. How much anti-D you should give. So if there is any feto-maternal hemorrhage, before 12 weeks, how much anti-D you will give? If it is before 12 weeks, 50 micrograms of anti-D. IM. If there is any feto-maternal hemorrhage after 12 weeks, you will give 300 micrograms of anti-D. Again, IM. And routine RH negative pregnancy mein, if ICT is negative at 28 weeks, you will give again 300 micrograms of anti-D. Routinely also at 28 weeks, you will give 300 micrograms of anti-D. This has been asked as a question. Post-delivery, within 72 hours, if baby blood group is positive, and direct Coombs test is negative, then again you will give 300 micrograms of anti-D. So you can give anti-D only if the baby's blood group is positive. If baby's blood group is negative, there is no point in giving anti-D, no? And direct Coombs test should be negative. So in mother, you will do indirect Coombs test, and in baby, you will do direct Coombs test. Okay? Right. Excellent, guys. So that's also one important point which can be asked and which has been previously asked. Right. So next, after Vasa Previa, next are these images. So somehow these images are favorite for the examiner. I don't know why, but they keep giving these images, right? But actually, this is an outdated classification. So if you observe here, when placenta is within how many centimeters from the internal os, you're going to call it as low lying. How many centimeters from the cervix you're going to call it as low lying? So low lying is within 2 centimeters from the internal os. So low lying is within 2 centimeters from internal os. Okay. So this is called type 1 placenta previa, which is within 2 centimeters from the internal os. It is 2 centimeters. Marginal is type 2, which is touching the os. So in marginal, you have 2A anterior, 2B posterior. From 2B, you're going to consider it as dangerous. From 2B, you're going to consider it as dangerous. Type 3 will be partially covering the os. Type 3 is partially covering the os. Type 4 will be totally covering the os. A complete placenta previa. Now, in exam, maximum times you will get the question on to differentiate between abruption and placenta previa, right? So how are we going to differentiate between abruption and placenta previa? So placenta previa is placenta lying in the lower segment or near or over the cervical os. Placenta previa will present to you with painless bleeding. And even if you see placenta previa in the first trimester, no need to worry, because placenta can move up along with the growing uterus. That we call it as trophotropism. Okay, to check for the trophotropism, USG should be done, that whether the placenta has moved up or not. USG should be done at how many weeks? To check for the trophotropism, USG should be done at how many weeks? So repeat USG again at 32 weeks. To see whether placenta has migrated up or not, you have to repeat the USG at 32 weeks. Now, abruption is premature separation of normally situated placenta. Placenta which is normally situated, when that gets separated, you call it as abruption. So abruption is in the upper segment. So there you have the muscle. There will be thromboplastin released, which will lead to painful bleeding. Abruption will be painful. Types of abruption, you will have revealed, where all the blood will come out. You will have concealed, where the blood will seep inside. And you will have mixed. Concealed when the blood goes inside, that it can result in a uterus called covular uterus. Covular uterus. Or you can also call it as uterine apoplexy. Okay, I have given the entire differences between the abruption and placenta previa as a table. Let us just go through this so that we can imprint how can we differentiate in the exam. The very first point which can help us to differentiate is placenta previa is painless. Abruptio is painful. Placenta previa, always the bleeding will be revealed. Abruption can be revealed or concealed or mixed. Placenta previa, you will have repeated episodes of bleeding. So they are painless, causeless, repeated episodes of bleeding. Each episode of bleeding is called warning hemorrhage. But abruption, once starts, it will keep on progressing. Placenta previa, as the blood entire thing is coming out, pallor will be in proportion. But in abruption, pallor will be out of proportion if it is a concealed variety. And in concealed variety, uterus will be more than period of gestation. Right? Preeclampsia. Whenever I listen preeclampsia, I will think in terms of abruption. Abruption mein preeclampsia is frequent. Okay. Uterus will be more than enlarged in concealed variety. Uterus is relaxed in placenta previa, but it is tonically contracted in abruption. It is tonically contracted in abruption. Malpresentations will be there in placenta previa. Here it won't be there. And what is that sign, what you see, which is very classical with placenta previa, guys? What is that sign which you classically see in the placenta previa? So it is the Stahlworthy sign. Stahlworthy sign. So what is this Stahlworthy sign? Whenever you push the baby into the pelvis, the presenting part will go compress the placenta and decrease the fetal heart rate. Release the baby, again heart rate will become normal. So somebody tells placenta previa, what strikes my brain 100% is Stahlworthy sign. Right, excellent. Now, can you give tocolysis? Absolutely no for abruption. Can be given in placenta previa. So can be given in placenta previa. So if somebody tells what is a mode of delivery for placenta previa, it is LSCS. Actually, type 1 and type 2 you can do vaginal delivery. Rest all it is LSCS. But in general, if somebody asks, it is LSCS. For abruption, everywhere it is vaginal delivery except when there is fetal distress. Now I'll just write few points about the management of placenta previa and abruption. Okay. So first abruption we will write. This is also very important. They will give you case scenario, guys. Now before that, tell me, I'll ask you one question. Patient has come to you with painful vaginal bleeding. Patient has come to you with painful vaginal bleeding. Blood pressure is 160, 110. Baby is dead. What should be the mode of delivery? You answer this, till then I'll write the abruption management. So in abruption, you check for the fetal status. So when you check for the fetal status, if baby is alive and if baby is in distress, then you'll go for LSCS. But if baby is alive and there is no distress, you will try for vaginal delivery. You will try for vaginal delivery. Right? That is by augmentation of labor or induction of labor. So you can augment the labor or you can do ARM. Right? If baby is dead, first I'll check for maternal status because DIC is very common in abruption. If DIC is present, first correct the DIC by giving fresh frozen plasma or cryoprecipitate. If there is no DIC, then I'll go for vaginal delivery. After you correct DIC also, you have to go for vaginal delivery. So all of you are absolutely correct. Excellent, guys. Your exam ready. So whenever baby is dead with abruption, you will go for vaginal delivery. So don't do a mistake here. Only if they tell there is distress, then go for LSCS. Otherwise, you're going to try for vaginal delivery itself. Okay, everyone crystal clear. Don't do mistake in this point. Okay. Right, next. If you have placenta previa before 37 weeks and if there is no fetal distress and if mother is hemodynamically stable, what are you going to do? What is the name of that management? So beyond 37 weeks, we'll go for LSCS. Again, not classical, lower segment. It's okay. Even if the placenta is in the anterior wall, I'll go lower segment cesarean itself. So I'll go for elective lower segment cesarean section. Except type 1 and type 2A. But I've never seen this specifically ask you, so just remember LSCS. Yes, it's called McAfee and Johnson's regimen. McAfee and Johnson's regimen. So here you're going to wait and watch, you're going to give her bed rest and you're going to give tocolysis if there are any uterine contraction. Most importantly, you're going to give steroids for the lung maturity, right? I will write about the steroids. So steroids, the dose of the steroids have been asked as an MCQ, guys. So steroids, you can give dexamethasone, 6 milligrams, 4 doses, 12 hours apart. Route IM. Betamethasone. Betamethasone is 12 milligrams, 2 doses, 24 hours apart. Again, this is IM. Okay? Right, next step. This protects from respiratory distress syndrome, necrotizing enterocolitis, and intraventricular hemorrhage. What is the only contraindication where steroids should not be given? What is the only contraindication where steroids should not be given? Chorioamnionitis. Only if there is infection, you should not give it. Now, an extraordinary important point. Can you give steroids to a diabetic mother? Can you give steroids to a diabetic mother for the lung maturity of the baby? Yes, but in diabetic mother, so in diabetic patient, you have to, diabetes mellitus, you have to give steroids plus increase the dose of insulin. So, this I feel they should ask you as a case scenario where some of you might not answer, some of you will answer. So, whoever knows this point are like, one step ahead. So, diabetes, we can give steroids, but we will increase the dose of insulin. Excellent, very good. Right. Now, let us see the two questions. I have two questions here. A primea gravida presents to a casualty at 35 weeks of gestation with acute pain abdomen for 2 hours, vaginal bleeding and decreased fetal movement. She should be managed by. A primea gravida presents to the casualty at 35 weeks of gestation with acute pain abdomen for 2 hours. Pain abdomen means abruption. She complains of bleeding and decreased fetal movements. Guys, whenever there is uterine contraction, obviously fetal movements won't be perceived. So there will be decreased fetal movements. Yes, it is B, not A. Did I tell there is decrease in the fetal heart rate? Listen to this point. Decreased fetal movements are due to the continuous contractions of the uterus. It is not due to the, it does not mean immediately that there is decrease in the fetal heart rate. So if I would have written in this question, there is decreased fetal movement with fetal heart rate of 90 beats per minute, then I would have agreed you all telling immediate cesarean. But as I've not mentioned fetal heart rate, I'm going to assume it is still normal because it is just 2 hours past. So we are going to go for immediate induction of labor. I hope all of you understood. Okay? No problem. I have put only questions which you might answer wrong. Next, a lady with 35 weeks of pregnancy presented with bleeding per vagina. Investigation shows severe degree of placenta previa. The treatment is. Second question. Very good, excellent. So, here it is 35 weeks. And I have just told that there is severe degree of placenta previa, which can be either type 2A or type 3 or type 4. But I didn't tell that patient is hemodynamically unstable or there is any fetal distress or anything. It's just a severe degree of placenta previa and they have come at 35 weeks. So you want to go for conservative or McAfee and Johnson's regimen. Good, excellent. I see majority of you answering C. So you're not falling into the traps. Very good, excellent. Morbidly adherent placenta. So morbidly adherent placenta is also called as placenta accreta spectrum. So this is mainly due to absence of Nitabux fibrinoid layer. This is mainly due to absence of Nitabux fibrinoid layer, or it can be due to absence of Decidia basalis, Right? Now, here you have accreta, increta and percreta. A for accreta, A for adherent to myometrium. I for increta, I for invades myometrium. invades myometrium. P. percreta, P penetrates myometrium to reach perimetrium. To reach perimetrium. So I will not just remember penetrate. I will remember penetrates to reach perimetrium. 3 P's. When I remember this, perimetrium is also called as serosa. Then only I'll remember that percreta is up to serosa. So as it can go up to serosa, it can also invade the bladder. So there is chance of bladder injury. Here what we are going to do? Here this is seen mainly whenever there is trauma to uterine wall. Don't forget this point. This is mainly due to trauma to uterine wall. DNC, LNC, LSCS, myomectomy, any trauma to uterine wall can act as a risk factor for morbidly adherent placenta. Okay. Now, so next is what are you going to do here? Again with Doppler, you are going to diagnose transabdominal sonography with Doppler. You can diagnose. Here you are going to go for classical cesarean section, followed by fetal extraction, followed by you are going to go for cesarean hysterectomy. You are going to remove the entire uterus. Now, only in certain conditions where she is a preemie, she want to preserve the uterus, there you will remove loosely adherent placenta and rest of the placenta you will leave behind. And you will do serial USG monitoring to see whether the placenta is coming out or not. But in all these patients, you are going to take a consent for hysterectomy. You are going to take consent for hysterectomy. Right? So I hope it is crystal clear and all of you could imprint these points in your brain. Right. Let's go to the next point, next topic. All of the following can be used in determining the expected date of delivery in IVF pregnancy, except, so normally the entire pregnancy is 280 days. So from LMP to expected date of delivery is 280 days. But in IVF, I precisely know when did the fertilization take place. Whenever is the day of oocyte retrieval, that is the day of fertilization. So I don't require to know this previous days because I know that this is passed outside itself. So I want to take it only from the fertilization to expected date of delivery. So that fertilization to expected date of delivery will be 280 minus 14. That is 266 days. That will be 266 days. Okay. Right. So from the day of oocyte retrieval plus 266 days can be used. Now if you are doing embryo transfer, already 3 days of embryo has been spent outside, so you are going to add only 263 days. If you are doing day 5 embryo transfer, you will do 261 days. These 3 formulas can be used. All these 3 formulas can be used. So what cannot be used? I've asked except. Guys, another point I'm telling you here. Most of the time you go wrong whenever the word expect comes. So please in exams, see the last sentence carefully. Did they ask except? If they ask except, interpret the question again properly in your brain. Because many times we can do silly mistake wherever that except word is there. Okay. So I'm trying to tell you all the common mistakes which you will do so that you avoid those mistakes. Okay. Naegeli's formula is not used for IVF pregnancies. But normally whenever they have regular menstrual cycles of 28 days, then you go for Naegeli's formula. You also have modified Naegeli's, that is LMP minus 3 months plus 7 days. I assume all of you know how to calculate. Now if somebody has 20 days, somebody has 30 days regular cycle, to this formula you are going to add plus 2. Somebody has 26 days cycle, to this formula you are going to do minus 2. How many ever days more or how many ever days less, those many days you have to add or those many days you have to remove. Okay. So that's about the Naegeli's formula. Now next important, if somebody has irregular cycles or if somebody has failure of contraception and they got pregnant, or if somebody has unknown NMP, what will you do for them? What will you do for them? So for irregular cycles or for unknown LMP, or for unknown LMP or for Failure of contraception. There was one clinical based question on this. Failure of contraception. There you are going to use the first trimester में crown rump length. Crown rump length. Excellent, excellent. Crown rump length is the most accurate. Crown rump length is most accurate. You can use crown rump length only up to 84 guys. After that, it becomes second trimester. So in second trimester, you can use biparietal diameter, but that will be plus or minus 2 weeks. Third trimester scan is not at all a good scan to check for the dating. Third trimester you can use femoral length, but it is plus or minus 3 weeks, so it is very inaccurate. Third trimester scan is mainly for the fetal growth. That's why it is called growth scan or interval scan. Third trimester scan, you actually have abdominal circumference you're going to check. How do you know when seeing anybody they're good, healthy or not? By seeing their pate. We know their weight by seeing their pate, right? So third trimester fetal growth you'll mainly assess by abdominal circumference. Next, coming to the obstetric score. So in obstetric score, what all points we know? That any pregnancy, gravida includes total number of pregnancies irrespective of the viability or irrespective of the outcome, and it also includes the current pregnancy. Para means all those pregnancies which have crossed the period of viability. Period of viability according to Indian Academy of Pediatrics is more than 24 weeks. Clinically, in India, they take 28 weeks, but according to Indian Academy of Pediatrics, it is 24 weeks. For exam purpose, take it as 24 weeks, but they'll usually not confuse you. So, any pregnancy which ends before 24 weeks, that we call it as abortion. Any pregnancy which ends before 24 weeks, we call it as abortion. So, can you answer this question now? So, mid-aged woman came to the OPD with twin pregnancy. Another mistake which I've seen multiple students do is they consider twin as 2 gravida or 2 para. Please don't do that mistake. Para should not include current pregnancy. So, twin will be 1 pregnancy itself. Okay? She already had 2 first trimester abortions and she has a 3-year-old female child who was born at the end of 9th month. So, what will be this? She has 4 pregnancies. 1 she's pregnant now, 2 abortions, and 1 previous good alive baby. So G4. How many? Para 1, living 1, because only 1 live baby. 2 abortions, right? GT-PAL will not be asked. So now we have come to the time where we should be like to the point, which is important and which will come in the exam. GT-PAL and all doesn't come, don't break your head. Okay? Right. So next we will go for the when do you call preterm? So preterm is anything before 37 weeks, right? Early term is 37 to 38 weeks plus 6 days. Mid term is 39 to 40 plus 6 days. Late term is 41 to 42 weeks. Now, elective deliveries, like, elective cesarean section or elective previous stillbirth, and now again I am planning to do an elective delivery for her. All elective deliveries should be planned in 39 weeks, guys. Okay? When do you call post-datism? When do you call post-datism? So post-datism is beyond 40 weeks. Post-datism is beyond 40 weeks. Whereas post-term is beyond 42 weeks. This is another point which can be difficult for you. So post-datism is beyond 40 weeks and post-term is beyond 42 weeks. Okay. Now pre-term में early term is less than 34 weeks. Early term is less than 34 weeks. So now recently you got a question that when do you call early onset preeclampsia? Early preterm. Early preterm is less than 34 weeks. So when do you call early onset preeclampsia? That's also before 34 weeks. Now let us quickly finish off about preterm. Preterm, what is the diagnostic criteria? What is the diagnostic criteria? This has been asked as a question. So diagnostic criteria for preterm is when they have 4 contractions in 20 minutes or 8 contractions in 60 minutes. plus cervix more than or equal to 2 centimeters dilated, 80% effaced. 80% effaced. So if you have written any other cervical changes, this is the one which you have to know, correct it and remember this only. So along with the contractions, you should have the cervical dilatation also. Cervix should be more than or equal to 2 centimeters dilated and 80% effaced. Predictors are on TVS, cervical length less than 2.5 centimeters and internal os diameter more than 8 mm. More than 8 mm. This is actually same for the cervical incompetence also. So what is another predictor? Another predictor what we have is fetal fibronectin. Fetal fibronectin. Between 22 to 34 weeks. More than 50 nanogram per ml. Can predict the labor in next 7 days. But if fetal fibronectin is absent, 100% she'll not go into labor in next 7 days. Okay. Prevention. Now another mistake which I've commonly seen from the student is regarding the prevention. So prevention, progesterone can be used as a prevention, cerclage can be used as a prevention. But please remember, progesterone cannot stop the ongoing contractions. So progesterone can keep the environment cool, calm, but it cannot go and stop the ongoing fight. It is like pacifier. But already fight starts, it can't do anything. So progesterone can keep the uterus relaxed, but it cannot stop ongoing contractions. So if contractions begin, then tocolysis should be given, not progesterone. So progesterone cannot act as a tocolysis. This is one important point which most students get confused. Next, regarding the cerclage. Let's complete about cerclages here. What is the most commonly applied cerclage? So most commonly applied cerclage is McDonald cerclage. You will use non-absorbable tapes like Marcelin tape, or actually in our hospital what we use is Ethilon at the level of internal os. So it's a pursue string suture at the level of internal os. It's a pursue string suture at internal os. Okay, if the McDonald cerclage fails, then you have modified Shirodkar, where you will put stitch submucosally, submucosal stitch. You also have abdominal cerclage. If this fails, we go for abdominal. So abdominal cerclage is called Benson and Durfee. Benson and Durfee. Okay, now another important. If she is come to you in the interpregnancy interval, if you are doing vaginally cerclage, the name of it is lash and lash. Just the names maximum they'll ask you. If there is a vaginally you are placing the cerclage, it is lash and lash. If you are placing it abdominally, then you'll go for laparoscopic. If cervix is already opening, then you put a stitch. It is called rescue cerclage. So rescue cerclage you put from 3 o'clock to 9 o'clock, 12 o'clock to 6 o'clock. This we call it as worm cerclage. What are the contraindications where you should not put a stitch? If membranes have ruptured, if there is ongoing bleeding, if there is infection, or if cervix is already more than 4 centimeter dilated. Okay, so contraindications has been asked as a question, guys. So where membranes have ruptured, if there is infection, if there is bleeding, if there is placenta previa, vasa previa, all that. Okay, and if the cervix is more than 4 centimeters dilated, obviously if there is a dead end anomalous fetus. Right, I think it's crystal clear and you could recall everything regarding the cerclage, right? So now coming to the management of preterm labor. So let us complete the management of preterm labor. So management of preterm labor and PROM is same, except in PROM there is a definite role of antibiotics, but in preterm labor there is no role of antibiotics. So you take a high vaginal swab for group B streptococcus. If it is positive, then you're going to give injection benzyl penicillin. Okay, at the onset of labor. This is to prevent neonatal meningitis. Now, I'll tell you a very simple way of remembering the management of preterm labor for you to solve the MCQs. If patient is more than 34 weeks, you don't require to break your head because lung maturity is over. So, deliver. But if the contractions are not very severe, labor can progress little, can consider steroids up to 36 weeks. I'm not telling pakka give steroids. I'm telling you can consider steroids up to 36 weeks. Okay? If the patient is less than 34 weeks, then what is very, very, very important? Tocolysis. Steroids. Now, very, very important. What is another third point which is very important, less than 34 weeks, which I have not yet written? I want you people to tell that. So, tocolysis, my drug of choice is nifedipine. Many times nowadays they are giving Pharmac with Opgyne. So, you should know everything about these drugs. Nifedipine is a calcium channel blocker. It can cause headache and ankle edema. You cannot give this in cardiac patients. So, for cardiac patients, drug of choice is atosiban, which is an oxytocin antagonist. Right? Next, highest side effects, maternal side effects are with beta adrenergics. Terbitalin, salbutamol, ritodrin, isoxsuprine. So they will cause hyperglycemia, diabetes mellitus. They will lead to hypokalemia, tremors. Maximum side effects to the baby is by indomethacin. It can cause premature closure of patent ductus arteriosus. So what did I not write? Yes, excellent guys. Magnesium sulfate for neuroprotection of the fetus. See, precise points are very important for you to, when you go back in order to answer. So magnesium sulfate for neuroprotection is important. Now, group B streptococcus injection, benzyl penicillin, how much dose? All that many times I've never asked, right? But they've definitely asked magnesium sulfate for neuroprotection. So these points should be known to you. So magnesium sulfate for neuroprotection is given between 28 to 32 weeks of gestation. Simple. So that finishes the preterm labor. PROM mein, only thing which is extra is in PROM there is a definite role of antibiotics. So we mainly give tablet erythromycin. Right? So here there is risk of chorioamnionitis. So in PROM, extra antibiotics should be given for all patients with PROM. Okay. Now postterm labor, I already told you that it is mainly it is beyond 42 weeks and postdatism is beyond 40 weeks. In postterm labor, what is important to us is Bishop score. Now Bishop score entire table, if you are not able to remember, at least remember what are the parameters we have under the Bishop score. So Bishop score may I remember it with DPS class. So D is dilatation of the cervix. Actually, length at dilatation will be ulta. Like dilatation will be 1 to 2 centimeters, 3 to 4, more than 5. Length will be 4, 2 to 3, 1 to 2, 0. It will be ulta. Next, length of the cervix. P is position of the cervix. C, consistency. S, station of the fetal head. Now there is a little controversy here. Datta gives score more than 9, but I am telling you as per the NICE guidelines, whenever score is more than 8, this is the minimum score. Maximum score is 13. So minimum score is more than 8, maximum score is 13. It is favorable for induction. it is favorable for induction. What is the drug of choice for induction of labor? It is misoprostol. So misoprostol, that is prostaglandin E1, is a drug of choice for induction. So if you are giving per oral, you can give 50 to 100 micrograms. But if you are giving per vaginal, it is 25 to 50 micrograms itself. You can give every 4 hours, maximum 6 doses. Side effect, it can cause uterine rupture. That is why this is contraindicated in previous LSCS patient. Now, important point, misoprostol is not contraindicated in postpartum. Postpartum hemorrhage when you are using misoprostol, or in active management of third stage of labor when you are giving misoprostol, it is not contraindicated in previous LSCS. But only when you are giving for induction of labor, it is contraindicated in previous LSCS patients. Am I clear with this point? Okay. Right. Now, if the score is less than 5, we need to go for cervical ripening. Now, don't ask me what to do between 5 to 8. So, mainly they have given more than 8 and less than 5. So, more than 5 also you can go for induction. But if it is less than 5, there is high chance that she'll end up in cesarean itself. It will be unfavorable or unsuccessful. So, first you do ripening of the cervix. So, how do you do ripening of cervix? Dinoproston, which is PGE2, Cerviprime gel. Okay. For augmentation, we go for augmentation means already contractions are there. Now I just have to increase the contractions. So for augmentation, it is ARM and oxytocin. How many trimesters do we have in pregnancy now? 4 trimesters. No more 3. It is 4. Everything in Obgyn is 4. First trimester is up to 14 weeks. Second is up to 28 weeks. Third is up to 42 weeks. Fourth trimester is post-delivery up to 12 weeks. Right? Everything is 14, almost 14. Post-delivery is only up to 12 weeks. Now, in pregnancy, we are going to give folic acid preconceptionally, right? So, folic acid is also, which vitamin is folic acid? Can you tell me? Just want to know. So, prophylactic dose, therapeutic dose. So, you're going to start 3 months prior or at least 1 month prior. Continue up to how many weeks? You are going to continue up to first trimester. So that is continue up to 14 weeks. Earlier it was only up to 12 weeks because earlier first trimester was 12 weeks. Then it changed to 13 weeks. Now it is 14 weeks. So you continue it up to, actually we continue up to 12 weeks, but yes, first trimester is now up to 14 weeks, so right, 14 weeks. Prophylactic dose according to India is 500 micrograms. Excellent. So folic acid is vitamin B9. Right? So according to India, it is 500 micrograms. According to WHO, it is 400 micrograms. If they ask you precisely WHO, go for 400. Otherwise, go for 500 only. Okay? Therapeutic dose, according to India, 5 milligrams per day. Everything is per day what I wrote. According to WHO, 4 milligram per day. What are the indications for therapeutic dose? Previous neural tube defect, family history of neural tube defects, patient on anti-epileptic, thalassemia and sickle cell anemia. New Williams has removed diabetes from this list. So I'm also not writing diabetes. I'm also not writing diabetes. So New Williams has removed diabetes. So I'm not writing it. Okay. If patient has folic acid deficiency, then what is the dose? If patient has folic acid deficiency, then the dose is 1 milligram per day. 1 milligram per day. High chance can be asked. We have finished. Everyone, did you imprint this? है ना? हो गया ना? Right, let's go to the next one. Iron. How much iron? Total requirement of iron in pregnancy is 1000 milligrams. Iron we give as per the Anemia Mukt Bharat. What is the color of the tablet in Anemia Mukt Bharat? Guys, read Anemia Mukt Bharat. Very, very important. 6 interventions, 6 categories. In pregnancy, the tablet is red color. So let's write with red. 60 milligrams of elemental iron. 60 milligrams of elemental iron plus 500 micrograms of folic acid for 180 days in pregnancy and 180 days postpartum. 180 days postpartum. 60 milligrams of elemental iron plus 500 micrograms of folic acid for 180 days in pregnancy and 180 days postpartum. So that's how we give the iron. Calcium. Calcium is 1000 milligrams. Postpartum, it can go up to 1000 to 1200 milligrams. Don't give iron and calcium together. No palak paneer. No iron and calcium together because calcium will inhibit the absorption of iron. So iron should be taken with lemon juice, not with calcium. Right? Next, along with calcium, you should ideally give vitamin D. Vitamin D dose is 600 international units per day. Right? Vaccination. What is a vaccine which we are going to do? Two injections, 2 doses of TD. 2 doses of TD 4 to 6 weeks apart. First dose at the first visit itself because we don't know the compliance of the lady. First dose at the first visit. Right? TD, tetanus and diphtheria. And if previous pregnancy within 3 years, then one single booster dose is enough. One single booster dose is enough. So if previous pregnancy is within 3 years, single booster dose is enough. All live vaccines are contraindicated and killed vaccines can be given. All live vaccines are contraindicated, killed vaccines can be given, right? So next, coming to the ANC, and I would like to also mention about the ANC visit that will finish this chapter. How many ANC visits according to WHO? Minimum. According to WHO, minimum 8 ANC visits. According to India, the minimum ANC visits are 4. Ideal visits are 12 to 14. Okay. Next, coming to the aneuploidies. So aneuploidies may we are mainly worried about. So I remember them as sometimes they can give you the karyotype picture and put these aneuploidies. Trisomy 13 के एज में पटाओ 18 में engage Edward 21 में settle down. So mainly you're going to screen for these aneuploidies. First trimester between 11 to 14 weeks, the best method of screening is you go for the first, you can always try with double marker, which is beta and papa. I remember it as beta and papa. Double marker, it is beta HCG and PAPA, that we are going to remember it as beta papa. You can do it between 11 to 14 weeks. But when you are considering only beta and papa, the detection rate is not so great. Okay. So who adds to this beta and papa to increase the detection rate? That is the combined screening method, which is 80% detection rate. And how am I going to remember? Beta, papa, auntie. Beta, papa, auntie. So what is this beta, papa, auntie? Beta HCG, PAPA plus NT scan. Beta HCG, PAP-A plus NT scan. You will not forget. You will definitely remember me telling beta, papa, auntie. So in this auntie is very important. That is NT scan. So NT scan is knuckle translucency scan. So NT scan is the knuckle translucency scan. NT scan should be done only when between 11 to 14 weeks of gestation, when crown rump length is between 45 to 84 mm. Crown rump length 45 to 84. 45 to 84. Okay. Next, it should be in neutral. Neck should be in neutral position, neither extended nor flexed. Mid sagittal section only you will take. Mid sagittal section you will take, and NT should be less than 3 mm to call it as normal. So in the nape of the neck, you're going to see the translucent area. In the nape of the neck, you're going to see the translucent area, and this translucent area should be less than 3 mm. Okay, and you should also see for the nasal bone. How does the nasal bone look like? Two equal to signs, like an equal to sign. Okay, like an equal to sign. Okay, so NB also should be seen. NT more than 3. NT more than 3. NT more than 3 or equal to 3. Most common aneuploidy is Downs followed by Turner's. Followed by Turner's. And most common congenital malformation. Most common congenital malformation is cardiovascular malformation. So most common aneuploidy is Downs followed by Turner's, whereas most common congenital malformation is cardiovascular malformation. Okay. Now, first trimester between crown rump length of 45 to 84 mm, it is NT. Second trimester, anomaly scan. You have nuchal fold thickness. Nuchal fold thickness cutoff is more than 6 mm. In nuchal fold thickness, if cutoff is more than 6 mm, it is an abnormal baby. You have to go further for karyotyping. See, every time I put these points, recent tiny CT, you got questions on this quadruple marker. So these are all expected questions which are definitely like they will turn out, right? So 15 to 20 weeks may you have triple marker, outdated again, quadruple marker. So quadruple marker is beta HCG, unconjugated estriol, alpha fetoprotein, inhibin A. Now in the recent exam, you got a question where they've asked all of the following are included in quadruple marker except. They wrote beta HCG, unconjugated estradiol, alpha fetoprotein, inhibin B. Now many students have a doubt ki estriol is also wrong, inhibin B is also wrong. What to mark? Guys, go for inhibin B. Inhibin B is not at all is not a part of quadruple. You can also unconjugated estriol also can be told, or unconjugated estradiol also can be told. That's fine. But inhibin B is not part of quadruple marker. Can you remember this point? Okay. Now Downs may H for HCG, high. I for inhibin A, I for increase, high. So beta HCG and inhibin A are increased. Rest two are decreased. Whereas Edward, everything will decrease. So quadruple, second trimester mein quadruple has 80% detection rate. Now you have one more method which has 99% detection rate. That is cell-free fetal DNA. It's also called as non-invasive prenatal testing. Cell-free fetal DNA or non-invasive prenatal testing. This has detection rate of 99%. So can I terminate any patient? Based on NIPT? This can be done as early as 10 weeks. I'll take all queries in the last. Okay. So Manish, you're asking me one query that if cervical ripening score is less than 5, why are we ripening when directly? Let us give a try, no? Why do you want to go directly for LSCS? Give a try and then go for LSCS. Trial is must. Yes, you can't terminate a patient based on NIPT. You definitely have to confirm. So what is the point which you're going to remember? That NIPT is only a screening test. It is not confirmatory test. So these are the confirmatory tests. So in exam, they can give you the images of these pictures. So here the needle is going up to. So first one, I think draw the needle only up to. Yeah, first one, please correct it. Draw the needle only up to amniotic fluid. If the needle goes only up to the amniotic fluid, you're going to call it as amniocentesis. If the needle goes up to the umbilical cord insertion, then you call it as cordocentesis. If the needle goes into the placenta, then you call it as chorionic villus sampling. These images can be given as an image-based question. Okay. Now, there are three modalities. What we have, these three modalities, we are just going to write chorionic villus sampling, amniocentesis, cordocentesis. Chorionic villus sampling is done between 11 to 13 weeks of gestation. Amniocentesis is done between 15 to 20 weeks of gestation. Cordocentesis is done between 18 to 20 weeks of gestation. In chorionic villus sampling, you're going to take trophoblast for karyotyping. Trophoblast for karyotyping. Okay. In amniocentesis, you're going to take amniocytes, that is fetal skin epithelial cells for the karyotyping. In cordocentesis, you're going to take fetal WBCs for the karyotyping. Culture results will take 1 week here, but within 48 hours. So cordocentesis is very quick. Within 48 hours, you can get, so cordocentesis is very quick. Next, most common complication is abortion. For all three, the most common complication is abortion. Abortion rate is 0.5% for chorionic villus sampling, less than 0.5 for amniocentesis, 1 to 2% for cordocentesis. So highest abortion is with cordocentesis. One specific complication only for chorionic villus sampling is the baby can have oromandibular defect or limb reduction defect Okay, so baby can have oromandibular defect or limb reduction defect, right? Now I want you to tell me one point here. If somebody asks you what is the most common complication of chorionic villus sampling, what will be your answer? So guys, I am going to give you this written PDF to you. Don't worry. I'm going to give you this written PDF, so don't worry. Okay. Yes. So the most common complication of chorionic villus sampling is abortion. Okay, so can you answer this? What is the optimum method of screening for chromosomal abnormality in a pregnancy at 13 weeks of gestation? What is the optimum method of screening for chromosomal abnormality in a pregnancy of 13 weeks of gestation? So in 13 weeks of gestation, excellent. See, I'm asking you the screening. So you can't do amniocentesis. As I'm asking you screening, you can't do amniocentesis. Now next, you can do combined screening test. Yes. NIPT, we never go it as a first line. So not NIPT. NT alone is not very good. So better is combined screening. Quadruple test will be done in the 15 to 20 weeks. So this is also not. So better go for B, combined screening test. Right, now coming to the miscarriage. So when do you call miscarriage? So miscarriage is expulsion or extraction of an embryo before 500 grams. Okay. What is the most common or less than 24 weeks of gestation as per India? What is the most common cause of abortion in India? Most common cause in first trimester is chromosomal abnormality. Chromosomal abnormalities. Genetic. More than 50% is genetic. In genetic, most common aneuploid is autosomal trisomy. Most common autosomal trisomy is trisomy 16. So most common autosomal trisomy is trisomy 16. Most common is genetic, and most common autosomal trisomy is trisomy 16. Most specific is Turner's. Most specific is Turner's. Okay. Between trisomy 16 and Turner's will be more common compared to trisomy 16. Least common autosomal trisomy which is associated with abortion is trisomy 1. What is the most common risk factor for these genetic abnormalities? Most common risk factor for these genetic abnormalities is maternal age more than 35 years. Maternal age more than 35 years. What is the most common second trimester abnormality? It is anatomical abnormalities. Most common cause for second trimester abortion is anatomical abnormalities. In anatomical also, it is mainly cervical incompetence. In anatomical also, it is mainly cervical incompetence. Most common cause of recurrent abortion is idiopathic. Most common cause of recurrent abortion is idiopathic. Okay. Now, if they ask you single most common cause for recurrent abortion, then it is APLA. Second most common cause for recurrent abortion is anatomical abnormalities. Genetic, all that can also lead to recurrent abortions. What will never cause abortions? What will never cause recurrent abortion? So what will never cause recurrent abortion is infections. Torch infections will never cause recurrent abortion. Torch infections will never cause recurrent abortion. So what is the most common cause of abortion? Can you answer this question now? What is the most common cause of abortion? Overfetal factor, maternal hypoxia, uterine fibroid, cervical incompetence. So it is mainly due to genetic. So genetic means you're going to take it as overfetal factor is nothing but genetic, yeah. Next, only syphilis, only congenital syphilis can present you with recurrent abortion, and that too it follows something called as Kassavitz's law. Kassavitz's law. Kassavitz's law. So what is this Kassavitz's law? With every pregnancy loss, gestational age will increase. So, like for example, this pregnancy, the patient had loss at 14 weeks. Next pregnancy, they'll have loss at 20 weeks, then loss at 28 weeks. So, with every pregnancy, with every pregnancy loss, gestational age will increase or outcome will improve. So, now coming to the most common cause of recurrent abortion is idiopathic. But if they ask you single most common cause, only one disease which will lead to recurrent abortion, then it is APLA. Okay. Next, coming to the what is APLA? So APLA may you should have one clinical and one biochemical criteria. So what is this one clinical or one biochemical criteria? Clinical vascular thrombosis, the death of the normal fetus more than 10 weeks. Morphologically normal fetus, death of more than 10 weeks, only one. Premature birth before 34 weeks in view of severe preeclampsia. More than 3 consecutive abortions of less than 10 weeks. I repeat again, please try to memorize. Death of a normal fetus more than 10 weeks, 1. Less than 10 weeks, 3 spontaneous abortion. 1 preterm labor before 34 weeks in view of severe preeclampsia. Antibodies are anti-cardiolipid antibody, anti-beta-2 glycoprotein 1 antibody, lupus anticoagulant. Medium to high titer at least 2 times 12 weeks apart. So you should have 1 clinical and 1 biochemical in order to call it as APLA. So what is the treatment for APLA? So the treatment for APLA is low molecular weight heparin plus aspirin. Okay. Next, coming to the types of abortion. The classical triad of the abortion is amenorrhea. Guys, I think many of you have the doubt about the PDF, no? So why am I writing the PDF is so that, I don't go very fast, so that you can register in your brain. So I will give you the full written PDF. Don't worry about that. Only thing is that I want peacefully you registering everything into your brain. Now, indeed, after the first break, I'll try to put the written PDF, already written PDF once to you. So don't worry about the PDF. Okay, I will send you the written PDF itself. Right. So the types of abortion we have amenorrhea, bleeding per vaginum, and pain abdomen. Amenorrhea, bleeding per vaginum, and pain abdomen. Okay. First, we have threatened abortion. Threatened means it is scaring you, but it is not going to get aborted. So, amenorrhea, bleeding, pain. Uterus will be equal to period of gestation. Os will be closed. Treatment, reassure. No need of giving progesterone also. Treatment is reassure, no need of giving progesterone also. Okay. Next. Next we have inevitable. What do you mean by inevitable? Inevitable means already the process of abortion has started and you can't reverse it back. Then you call it as inevitable. Again, in inevitable, you have amenorrhea, bleeding, and pain. No products have gone out, so uterus will be equal to period of gestation. Os will be closed. Os will be, as the process of abortion has started, os will be open. Os will be open. What is the treatment? Treatment will be MTP. Terminate. Okay. Incomplete. Incomplete may, again you'll have amenorrhea, bleeding, and pain. Uterus will be, as the process of abortion has already started, uterus will be less than period of gestation. Uterus will be less than period of gestation. Here os will be open. Again you have to go for MTP. Okay. Complete abortion may, all products have gone out, so pain and bleeding subsides. Pain and bleeding decreases. Uterus will be less than period of gestation. Os will be closed. What is the treatment? Again, reassure or plus or minus antibiotic you can give. Usually we prefer doxycycline. Missed abortion, which is also called as incarcerated or carneous mole. Here also you'll have the same triad, amenorrhea, bleeding and pain, or you can have brownish discharge. Uterus will be less than or equal to period of gestation. Os is closed. This is a USG finding. We will go for MTP. So everywhere os is closed except those which are starting with I. That is inevitable and incomplete. Everywhere os is closed. Only those which are starting with I. That is inevitable and incomplete os is open. Remember this because they'll give you a case scenario on these. They'll give you a case scenario on these. Okay. Right. Now, what is the clinical USG based finding? When crown rump length is more than 7 mm, this is for missed abortion. Missed abortion, when do you call it as a missed abortion? When crown rump length is more than 7 mm with no heartbeat, or when mean sac diameter is more than 25 mm with no embryo. Remember these 2 points. The next 2 is fine. If you don't remember, these two I want you to remember. So, crown rump length is more than 7 mm with no heartbeat, or mean sac diameter is more than 25 mm with no embryo. Right? Actually, this is also called as blighted ovum. Blighted ovum. Coming to the MTP Act. So, MTP Act, again, it is very, 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 very important. So, new MTP Act has come in 2021. So, now according to the new Act, MTP will be done up to, MTP is done up to 24 weeks for eugenic, genetic abnormalities, for victims of rape, incest, and change in marital status. Change in marital status. Change in marital status means she got divorced or husband died, So she can get it aborted up to 24 weeks. Okay. For contraception failure, very important. For contraception failure, MTP is only up to. So for contraception failure, MTP is up to 20 weeks itself. Right? Next, for lethal anomalies or incompatible with living, lethal anomalies like anencephaly, where they cannot live at all, where those babies can't survive at all. So for lethal anomalies, MTP is done up to no upper limit for MTP. No upper limit for MTP. Who will decide this is a lethal anomaly? This is decided by a board of doctors. This is decided by a board which consists of pediatrician, obstetrician, sonologist, and members notified from the state government. Okay, up to 12 weeks. Right. So up to 20 weeks, one doctor opinion. Up to 20 weeks, one doctor opinion. 20 to 24 weeks, it is two doctor opinion. Up to 20 weeks, it is one doctor opinion. 20 to 24 weeks, it is two doctor opinion. Next, another last point is here unmarried women. Married, it need not be married woman. It is any woman with her partner can come and get MTP done. So woman and partner can, and only woman consent is enough. She need not be married. And we will maintain the privacy. If less than 18 years, first you have to inform police. The police. Then you take the guardian consent. Okay. So that is everything about the MTP Act, which should be known to you, right? So all of you could register this. Next, coming to the what are the drugs we have. So in the first trimester, you can give mifepristone 200 milligrams per oral after 24 hours. So 24 hours, actually as per AC Williams, it is 24 hours. As per WHO, it is after 48 hours. 800 micrograms, it is micrograms. You can give PV or sublingual or buccal or oral. Again, this should be registered in your brain. What is the other name for mifepristone? Okay. So what is the mifepristone? Mifepristone is also called RU486. So mifepristone, it is 200 milligrams oral, and after 48 hours, you can give misoprostol 800 micrograms PV or sublingual or buccal, right? Misoprostol alone also can be given. So misoprostol alone is 800 microgram, and then you repeat it every 3 hours, total 3 doses. 800 micrograms, then you repeat it every 3 hours, total 3 doses. Second trimester, so first trimester, before any abortion drugs, whichever you are giving, before giving these drugs, you should definitely go for USG. So USG, you should mandatorily do USG, and then you are going to go for these drugs. Okay. Second trimester, what drugs we have? Again, mifepristone 200 milligrams per oral. After 24 hours, you can give misoprostol 400 micrograms. 400 micrograms every 3 hours, total 5 doses. Or you can directly give 400 micrograms every 3 hours, total 5 doses. You can also give dinoprostone and concentrated oxytocin. Okay, next. Or in second trimester, another drug what we can give is, you can give intra-amniotic instillation of hypertonic urea and normal saline, and extra-amniotic instillation of ethacridine lactate and prostaglandins. Ethacridine lactate and prostaglandin. Okay, so you can give intraamniotic instillation of hypotonic urea and normal saline, or you can give extraamniotic instillation of ethacridine lactate and prostaglandin. These are also what can be given in the second trimester. But first trimester, the best is this MIFI and MISO regimen. Second trimester, the best is giving only the MISO. You also have surgical methods. So what are the surgical methods we have? This is the surgical method. So these images are again important. So what is the first image? First image is menstrual regulation syringe. First image is menstrual regulation syringe. This is a 50 ml syringe to which Karman's cannula will be inserted to aspirate products of conception. Up to how many weeks you can use this? Only up to 6 weeks. Only up to 6 weeks you can use this. Next, if you are observing, this is the manual vacuum aspiration syringe. How do you know that this is manual vacuum? So in exam, you will have two pistons, the two valves. The two valves is the one which are going to tell us that this is manual vacuum aspiration syringe. So manual vacuum aspiration syringe is 60 ml syringe, which creates a negative pressure of 660 mmHg. This is done under mild sedation. It can be done up to 12 weeks. Does it require electricity? Does it require electricity? No, manual vacuum aspiration syringe does not require electricity. Next, coming to suction and evacuation. This creates a negative pressure of 600 mmHg, done under general anesthesia. Up to 12 weeks you can do it. Up to 12 weeks you can do it. Right? This requires electricity. Both manual vacuum aspiration and suction and evacuation, you will put Karman's cannula. You will put Karman's cannula. How do you decide the size of the Karman's cannula? So the Karman's cannula, this end will be like this. Size of the Karman's cannula is equal to gestational age in weeks in even number. So if she's 8 weeks, you are going to use 8 mm cannula. If they're odd number gestational age, like if she's 9 weeks, you're going to use 8 mm cannula itself. So if she's 8 weeks, you're going to use 8 mm cannula. If she's 9 weeks, you use 8 mm. Okay. Odd number gestational age also, you're going to use even number cannula itself. Now, the other surgical methods what we have is DNC, dilatation and curettage. This is a uterine curette. This is a uterine curette. It will have serrations in the center and openings at the end. One end is sharp, one end is blunt. So in gynec, you will use sharp end. But in OBS, like in this abortion case, if you use sharp end, it can lead to perforation of the uterus. So you'll use only blunt end. Next, you can also do dilatation and evacuation. So dilatation and evacuation, you're going to use ovum forceps. How are you going to determine ovum forceps? It has no catch and it is like a cup line. It is like a cup line. Okay. Last resort for any abortions is hysterotomy. That is, open up the uterus and remove the contents and close it back. Hysterotomy, not hysterectomy. It is hysterotomy. Okay. Now, can you answer this question, guys? So that we finished abortion revision. So we finished abortion revision where MTP and all is very, very important. A 32-year-old woman presents for 12 weeks scan. She has been pregnant once before but had a first trimester miscarriage. She reports no problem with this pregnancy and has no vaginal bleeding or spotting. The scan shows no fetal cardiac activity, but there is a small gestational sac. What is the likely diagnosis? Yes. So it is a missed miscarriage. Missed miscarriage because they are telling that she has come at 12 weeks. There's only one gestational sac but no baby inside. It is a missed miscarriage. Next. Ectopic. What is the most common site of ectopic? Fallopian tube. Most common site is fallopian tube. In fallopian tube, see, normally fertilization takes place in ampulla and baby remains there itself. In fallopian tube, most common is ampulla. Least common in the fallopian tube is interstitial. Most common is ampulla, least common is interstitial. What is the earliest to rupture and most common to rupture? Earliest to rupture and most common to rupture? Earliest to rupture and most common to rupture is isthmus. Last to rupture will be interstitial. It will rupture by 12 weeks. Isthmus can rupture by 6 weeks. Interstitial will rupture by 12 weeks. Why? Because interstitial is supported by uterine musculature. Okay. Next, coming to the next one. What is the most common cause of ectopic? Again, this was asked in the recent INECET. PID, followed by previous ectopic, but most common is PID. When do we have highest risk of ectopic? Highest risk, not most common. I'm asking highest risk. So highest risk is previous tubal surgeries. Any tubal surgeries can damage the tube. Right. Now coming to the unruptured ectopic. So unruptured ectopic is like a silent bomb sitting inside the fallopian tube. Right. So unruptured ectopic, there are no, most of the time they are asymptomatic. The investigation of choice is TVS, where you will see gestational sac in fallopian tube, which we call it as Bagel sign. And you will have pseudo sac in the uterus, which will be center in position. And on Doppler, what are you going to see? Ring of fire appearance. Arcagola. So on TVS, it will be gestational sac in the fallopian tube, which will be called as Bagel sign, pseudo sac in the uterus, and on Doppler, you are going to see ring of fire appearance. Okay. Next, gold standard is laparoscopy. You can also measure serum progesterone, guys. So if serum progesterone is more than 25 nanogram per ml, it rules out ectopic. So it doesn't help in diagnosis of ectopic, matlab it can rule out ectopic. And when you do culdocentesis, that is aspirate some blood from the pouch of Douglas, on culdocentesis, if blood does not clot, then it is ectopic. If blood clots, it is some from vessel, not ectopic. But these are not most important. What is most importantly done is ultrasound, where you see the Bagel sign and ring of fire appearance. The management of ectopic is very important, which you are going to memorize it now along with me. Okay. There are 3 modalities of management. One is expectant, second is medical, third is surgical. So there are 3 modalities of management. One is expectant, second is medical, third is surgical. So where are we going to do expectant management? So expectant management, patient should be ready for follow-up. Here you are going to just do only follow-up. So patient should be ready for follow-up. Sac size less than 3.5 to 4 centimeters. See, according to NICE guidelines, it is less than 3. According to Datta, it is less than 4. Take it up to 4, no problem. So less than 4, you can do expectant management. Okay. Next, no FHR. FHR should be not there. No pain or mild pain. Beta HCG should be less than 1000 international units per liter. When do you do medical management? When sac size is again less than 4 centimeters, I'm going to write, because NICE is less than 3.5, but Datta is less than 4. Stick to less than 4 for exam, because they might give us 4. You can go for expectant or medical. No FHR. Again, no pain or mild pain. Beta HCG should be less than 5000. When will you do surgical? When sac size is more than 4 centimeters with FHR or beta HCG is more than 5000. or beta HCG is more than 5000. Medical may you give methotrexate. You can give multiple dose and single dose. Which is preferred? Single dose is preferred. 50 milligram per meter square IM. IM. This question, from this part, the question has come in the recent INCT. See, already almost 4 or 5 questions have, from whatever we have discussed, has been coming. The recent INCT they have come. So, methotrexate 50 milligram per meter square IM. Then you check the beta HCG on day 2, day 4, day 7. Beta HCG should drop more than 15%. Drop in 15% from the previous value, she is responding. If drop is less than 15%, repeat one more dose. Maximum you can give 3 doses. Next, surgical management may you can do salpingectomy, complete removal. Salpingotomy, you incise, remove and suture it back. Salpingostomy, you incise, remove and keep it open. Best is salpingectomy. Because if you do otomy or ostomy, there is a chance of recurrence. Because if you do otomy or ostomy, there is chance of recurrence. Okay. So that is why what you're going to do is ectomy. So where will you do otomy or ostomy? If she has only one tube left, there you prefer going for otomy or ostomy. Matlab she is a prime, she want to conceive in future and already one tube you have removed, only one tube is there. For them, we'll go for otomy or ostomy. So this is everything about the medical expectant and surgical management. Many times they have asked questions from this. Okay, right? So beta HCG less than 1000, expectant less than 5000, medical more than 5000, surgical. FHR positive, surgical. Sac size more than 4 centimeters, surgical. Next, just know the name of these criteria, guys. Abdominal pregnancy, it is called Studi-Ford's criteria. So who will have abs? Stud-like person will have abs. So abdominal pregnancy, it is called Studi-Ford's criteria. Ovarian pregnancy. Ovarian pregnancy, Spiegelberg's criteria. Ovarian pregnancy, it is called Spiegelberg's criteria. Cervical pregnancy, it is called Rubin's or Parmann's criteria. Cervical pregnancy, it is called Rubin's or Parmann's criteria. This was asked as a question. Right. Next, if a patient comes to you with amenorrhea, pain abdomen, and mild bleeding for vagina, with per abdomen, tense, tender, guarding, rigidity, Cullen's sign, this is a periumbilical bluish discoloration, Gray Turner, all this won't be seen. That is bluish discoloration in plants. Danforth, that is shoulder tip pain. On PV, cervical motion tenderness is positive. Severe pain on moving the cervix and fullness in the pouch of Douglas. This is ruptured ectopic. So ruptured ectopic may you don't have time. You should be quick. So what are you going to do in ruptured ectopic? Immediate laparotomy, followed by salpingectomy. Remove that tube, plus simultaneous resuscitation. So you have to do immediate laparotomy followed by salpingectomy plus simultaneous resuscitation. So that is about the ruptured. Ruptured, how will they give you an exam? Amenorrhea for a very less time, and then patient is having shock. There will be shock. And then all tenderness, guarding, rigidity, rebound tenderness. So those symptoms, if they give, it is a ruptured ectopic. Early pregnancy is a key thing which you have to see for. Okay. That's about the ectopic. Right. Next, coming to the. So we'll see one question again here now. A 28-year-old in her first pregnancy at 16 weeks of gestation with severe hyperemesis gravidarum. Her blood pressure is 150/96 with 3 plus proteinuria. Her booking blood pressure is noted to be 110/170. Abdominal examination reveals that symphysiofundal is equivalent to 22 centimeters. What is the diagnosis? Right, what is the diagnosis here? So this is molar pregnancy. So this is the molar pregnancy. Why? I gave hyperemesis gravidarum, which is seen in molar. Early onset preeclampsia, which is seen in molar. Uterus is more than period of gestation, seen in complete molar. So this is molar pregnancy. But before we go to molar pregnancy, I want to tell you one more very important, okay? So very important thing. Guys, be focused, stay focused, keep listening. You're revising the most important topics, and we've already finished majority of like very important topics. I hope you could imprint all this. Now, if UPT is positive, but there is no gestational sac on TVS, what should be your next step? If UPT is positive, but there's no gestational sac on TVS, what should be your next step? UPT is positive, but there's no gestational sac on TVS. What should be your next step? You have to measure the serum beta HCG. Serum beta HCG. If serum beta HCG is less than 1500 to 2000 international units, if serum beta HCG is less than 1500 to 2000 international units, then that is a minimum beta HCG to visualize gestational sac on TVS. So obviously you will not see the sac. Obviously you will not see the sac. What you're going to do is, you're going to repeat the beta HCG. You're going to repeat the beta HCG after 48 hours. So you have to repeat the beta HCG after 48 hours. If the beta HCG rises more than 63%, if there is increase more than 63% after 48 hours, then it is an intrauterine pregnancy. If the beta HCG increases by more than 50% but less than 63%, then it is an ectopic pregnancy. If there is fall in beta HCG or rise is less than 50%, then it is a biochemical or abortion. Bachcha nahi hai, only chemical pregnancy it is. Okay. So I'll give you an example. Quickly answer. Patient beta HCG is 1000. After 48 hours, it has become 2000. What is your diagnosis? Is it intrauterine or is it ectopic or is biochemical? Patient beta HCG today is 1000. After 48 hours, when you have checked, it is 2000. So is it intrauterine or ectopic or biochemical? So that is it is an intrauterine pregnancy. 1000 to 2000 is a 100% rise. 1000 to 2000 is a 100% rise. So it is an intrauterine pregnancy. So coming to trophoblastic disease, GTD, you have complete mole and partial mole. Complete mole looks like this. That is grape-like vesicles or sago grains. So complete mole, the classical triad for complete mole and partial mole, both the clinical picture will be amenorrhea again. They'll have bleeding per vagina and pain abdomen. Bleeding per vaginum is predominant. They can also give you the history of passage of grape-like vesicles. Passage of grape-like vesicles. Okay. Complete mole on examination. Complete mole on examination. Uterus will be more than period of gestation. Soft and doughy. There is no fetus here. Partial mole, uterus will be less than period of gestation or equal to, fetus is present here. So you can have external and internal ballotment positive. What is the investigation of choice in these patients? The investigation of choice, what you're going to see here is, you're going to see the snowstorm appearance. On TVS, the snowstorm appearance is very classical. Snowstorm appearance. Right? So this is a complete mole because I see only snowstorms. I don't see the fetus. This is a partial mole because I'm seeing fetus with placenta having the moles. So this is partial mole. This is a complete mole. Okay. Next, what are the complications associated with this? What are the complications associated with this? So complications, what you're going to see is there will be hyperemesis gravidarum, early onset preeclampsia. There will be bilateral theca lutein cyst. What will be the treatment for this bilateral theca lutein cyst? Just cyst regress, post-molar evacuation. Cyst regress, post-molar evacuation. So don't do anything. Next, as alpha subunit will look like TSH, it can cause thyrotoxicosis. Next, there will be pulmonary embolism. They can also progress into choriocarcinoma. Okay. Treatment is suction and evacuation. If the age of patient is more than 40, complete mole, family complete, then you can go for hysterectomy. Am I clear? Okay. By doing hysterectomy, what are you decreasing? What incidence are you decreasing? So by doing hysterectomy, you are decreasing the incidence of pulmonary embolism, not choriocarcinoma. So it decreases pulmonary embolism. So contraception of choice. You have to follow up these patients for 6 months. So contraception of choice is combined oral contraceptive pills, or you can give condom. IUCD is absolutely contraindicated. Very good. Excellent, Hemant. Very good. Okay, let us now go for hypertension in pregnancy. So let us solve this question for hypertension in pregnancy. A 32-year-old patient has blood pressure of 150/100 at 32 weeks of gestation. There is headache and blurring of vision and proteinuria of 3+. Her blood pressure before pregnancy is 150/90. What is the diagnosis? Very good. So as blood pressure is present before pregnancy itself, it is chronic hypertension. And with chronic hypertension, they're having headache and blurring of vision. So it is also superimposed preeclampsia. So this is chronic hypertension with superimposed preeclampsia, which all of you have answered it correct. Okay? Excellent. That's absolutely correct. Now, next, tell me this one. If I write her blood pressure before pregnancy is 120/80, then what is the diagnosis? If I write that her blood pressure before pregnancy is 120/80, then, so what is chronic hypertension? It is blood pressure before pregnancy or blood pressure before 20 weeks. If chronic hypertension is associated with end organ damage, it is chronic hypertension with superimposed preeclampsia. Now, if blood pressure before pregnancy is 120/80, this doesn't become chronic hypertension. But there is headache, blurring of vision, which is end organ damage. And there is proteinuria. So this is severe preeclampsia. So now it will go into severe preeclampsia. Okay? Right? Right, next step. If in the same question, I write, there is no headache and blurring of vision. So now the question is, 32-year-old has blood pressure of 150/100 at 32 weeks of gestation. There is no headache or blurring of vision. But there is proteinuria of 3+. Her blood pressure before pregnancy is 120/80. What is the diagnosis? Now what will be your answer? Now I changed it to there is no headache and blurring of vision. Then it will become mild preeclampsia. Right? Another 15 minutes, I'll give you a break. Please, another 15 minutes, I'll give you a break. Correct. Excellent. Okay. So when do you call gestational hypertension? So let me change the question now again. Her blood pressure before pregnancy is 120/80. There is no headache and blurring of vision. There is no proteinuria of 3+. Now, what will you call this as? You don't have the option, but you tell me what you call this as. There's no headache or blurring of vision. There's no proteinuria. Now, what will you call it as? So this becomes gestational hypertension. So this basic definition, I'm assuming all of you know. So we are going to be quick here. So now I quickly repeat once again. So gestational hypertension is blood pressure more than 140/90 after 20 weeks or after 20 weeks, and blood pressure should come back to normal within 12 weeks of delivery. If blood pressure starts before pregnancy or before 20 weeks, or blood pressure which is starting after 20 weeks and not coming back within 12 weeks of delivery, we call it as chronic hypertension. If gestational hypertension is associated with proteinuria, you call it as preeclampsia. If there is end organ damage, need not have preeclampsia, need not have proteinuria. If there is end organ damage, need not have proteinuria. Okay. Now, when do you call mild and when do you call severe? Mild preeclampsia is when blood pressure, systolic blood pressure is less than 160. Severe is when systolic blood pressure is more than 160. Diastolic blood pressure is less than 110. Diastolic blood pressure is more than 110. Okay. Now here end organ damage is not there. No end organ damage. Here end organ damage is present. End organ damage is present. Proteinuria is there in both. In severe, proteinuria need not be there, but in mild, proteinuria is must. We deliver mild preeclampsia by 37 weeks and we deliver severe preeclampsia by 34 weeks. When do you call early onset preeclampsia? If they develop preeclampsia before 34 weeks, we call it as early onset preeclampsia. Am I clear? Now let us see why do we have these? Why do we have this? Okay. So this is mainly because of the improper trophoblastic invasion. Improper trophoblastic invasion. Some of the trophoblasts, that is extravillous cytotrophoblasts, interstitial extravillous, endovascular extravillous. These cytotrophoblasts enter the spiral arteries and break the elastic lamina of the spiral arteries. These enter the spiral arteries and break the elastic lamina of the spiral arteries. Okay. Now, if this happens 2 times, so primary wave will start at 12 weeks, secondary wave will start at 16 weeks. By doing this, they are making the spiral arteries broad. They are making the spiral arteries broad so that more blood can go into intervillous space. This is what is normal and this is called as trophoblastic invasion. They have asked which trophoblast invades which artery. Extravillous cytotrophoblast. They are cyto guys. Extravillous cytotrophoblast invades spiral arteries. Now, why do we see preeclampsia? This is due to defective secondary wave of trophoblastic invasion. Defective secondary wave of trophoblastic invasion. Okay. So, because of the defective secondary wave of trophoblastic invasion, how are the spiral arteries here? So, spiral arteries are narrow. Spiral arteries are narrow. So as spiral arteries are narrow, the blood flow to the intervillous space is decreased. So the oxygen supply to the fetus also will be decreased. So there is uteroplacental insufficiency. Because of this uteroplacental insufficiency, baby will secrete from the placenta. You will have inflammatory mediators and you will have increased vasoconstrictors and decreased vasodilators. Increased vasoconstrictors and decreased vasodilators. Once in exam you got a question telling what are the vasoconstrictors which are going to increase and what are the vasodilators which are going to decrease. Soluble FMH like tyrosine kinase 1, SFLT1, SFLT1 increase. Thromboxane A2 will increase. Endoglins will increase. What will decrease? Nitric oxide, placental growth factor, prostacyclin. These vasoconstrictors will enter into mother circulation and cause hypertension in pregnancy. So who is the villain in gestational hypertension or preeclampsia? Who is the villain? It is mainly the fetus. It is mainly the fetus. Okay? Right? Just let me finish this one preeclampsia. I'll give you a break. Only preeclampsia. Okay? Right. So now coming to the, because of these vasoconstrictors entering into the mother circulation, mother is going to have preeclampsia. Right? So it is mainly due to baby. So if somebody asks you what is the definitive management, it is terminate the pregnancy or deliver the baby. The definitive management is delivery of the baby. Okay. Now, if you understand the entire definition, why did they give it the hypertension after 20 weeks is, so by 16 weeks, normally there will be secondary wave of trophoblastic invasion. So whenever by 16 weeks, secondary wave does not take place, by another 4 weeks, you will have these vasoconstrictors increasing. That is why its definition is after 20 weeks. Now, as the villain is baby, after baby goes out, automatically all these vasoconstrictors should come down. So post delivery, what will happen? There will be decrease in the all these vasoconstrictors. Only then we can tell that you can blame the baby. If after delivery also hypertension is still there, then you can't blame the baby, blame mother itself. Right? So because of this vasoconstrictor, what are all the end organ damage we'll have? First, headache. Headache and cerebral vessel segmental vasoconstriction will lead to headache and vomiting. Pulmonary vessel vasoconstriction will lead to pulmonary edema. These are all impending signs. Retinal vessel vasoconstriction will lead to reversible blurring of vision. Reversible blurring of vision. Small vessels under liver capsule start to rupture. So that will stretch the Glissen's capsule. So that will lead to epigastric pain. And not only epigastric pain, there will be increased LFT because of the periportal necrosis in the liver. In kidney, decreased GFR, so oliguria. And there will be increased renal function test, that is creatinine and all. Which is the most common organ to be affected and first to be affected? Most common organ to be affected is kidney. That is why we check for oliguria. That is why we check for oliguria. So to know for fetal well-being, you have to check for the umbilical artery Doppler. To know for the fetal well-being, you have to check for the umbilical artery Doppler. So when you are checking for the umbilical artery Doppler, this is a systole, this is a diastole. This is a systole, this is a diastole. Okay? When there is reduced diastolic flow, you deliver them by 37 weeks. Next, there can be no diastolic flow at all. That's called absent diastolic flow. Absent diastolic flow, you deliver them by 34 weeks. Reverse diastolic flow, you deliver them by 30 to 32 weeks. 30 to 32 weeks. Okay. Now, another important point, what is the predictor? How can we prevent? Predictor is persistence of diastolic notch. Persistence of diastolic notch up to 20 to 24 weeks. Ratio of SFLT1 to PLGF. Mean arterial pressure becoming more than 90 mmHg, rising more than 90 mmHg. How will you prevent it? So prevention, aspirin, and those who are deficient in calcium deficiency, you give calcium. Calcium deficiency, you give calcium. management of preeclampsia, definitive is delivery. So delivery में gestational hypertension you will deliver by 39 weeks. Mild preeclampsia, deliver them by 37 weeks. Severe preeclampsia, deliver them by 34 weeks. Severe preeclampsia with impending signs, you deliver them by immediate delivery, and you are going to give them magnesium sulfate, prophylaxis. Okay, next, non-specific management is antihypertensive. Drug of choice is labetalol, alpha plus beta blocker, right? Avoided in asthmatics, contraindicated in asthmatics. Don't alternate drugs. Alpha methyl-dopa causes postpartum depression. Nifedipine, hydralazine. What drugs you will avoid? Contraindicated drugs are AC inhibitors, ARBs, diuretics. Nitroprusside also you should not give. Okay. Gestational hypertension, do not admit. No need to admit, no need to do any blood test, just blood pressure every weekly. Mild preeclampsia, you have to do preeclampsia investigations every week. But no need to admit. Only severe preeclampsia you will admit and then treat her. Okay. Can we solve these questions now? A 40-year-old woman presents at 32 weeks of gestation in her first pregnancy with a blood pressure of 143/90. Blood pressure at the beginning of her pregnancy was 160. Quantitative test is indicated no proteinuria. She feels well with no headaches or blurring or visual disturbance. Now what you have to tell me is, anytime you see a clinical scenario, first ask yourself diagnosis. Then you will be able to answer the answer. First ask yourself diagnosis. Yes, this is gestational hypertension. Okay. So do not admit the patient to hospital or treat hypertension. No, you have to treat hypertension, no, but no need to admit. So option A is wrong. Correct? So you have to treat hypertension. They're telling do not admit or treat. You have to treat hypertension by giving antihypertensives. Treat hypertension with oral antihypertensive. Take blood pressure at least twice per week. Gestational hypertension, I told no need to take blood tests. So this is not the answer. Now, do not admit the patient to hospital, but here you have the word or. Here, do not admit, comma. Treat hypertension with oral antihypertensives. Take blood pressure at least twice per week. No need of blood test. So this is the appropriate answer. Comma or can change the answer. Please read carefully. Okay? Right. Next. A pregnant lady at 32 weeks of gestation period presents with a blood pressure of 160/110. Proteinuria with retinal hemorrhage. What is the definitive management of choice in this case? Guys, I'm asking you the definitive management. Excellent. So the next question, the definitive management, as this is severe preeclampsia with impending signs, because she's having retinal hemorrhage. So the definitive management is termination of pregnancy. The definitive management will be termination of pregnancy. What is the next step for this patient? Next step, magnesium sulfate. Definitive management, termination. Okay? Right. So I will give you a break. So I have been provided 6 hours. I have beautifully planned revising all topics in this 6 hours. You don't take tension ki bhai I'll be able to complete or not. That is my headache. Your headache is only one thing. Try to give your 100% attention here and try to grasp as much as possible. If you have any queries after the break or before the break, I'll definitely answer. Entire class is over. You have a doubt now, write it somewhere. After the class, I'll speak to you for all your doubts. Okay? Now you want, and many students have been asking about annotated PDF. I will be providing that. I will be providing that if possible. Now only I'll provide you. Don't worry. Okay? So go have some tea or coffee and come back. Then we'll resume back and we'll further discuss. Okay? So then the 15 minutes. After 15 minutes, the it will again resume back. After 15 minutes, it will again resume back. The notes will be provided in the app itself. The notes will be provided in the app itself. 15 minutes. Look for 15 minutes and come back.